Good afternoon. Welcome to Psychiatry Family Medicine Grand Rounds. There's no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for the presenters, please hold until the Q&A segment at the end of the talk. If you're attending virtually and have a question, please enter it into the Q&A section and we'll be glad to ask that question for you. A link to the event evaluation will be shared at the end of the program. It is now my pleasure to introduce Dr. Monica Newton. She is our Family Medicine Program Director and President of Georgia Academy Family Physicians.
All right, great. Thank you. Thank you. Thank you all for being here. I think this is a great collaborative topic that we can all learn a lot about as we are entering a new age of using AI to both deliver excellent patient care, but also using it as a teaching tool. So I heard some colleagues of our presenters today present at the Georgia Academy of Family Physicians and asked them to come here and talk to you all about AI being used as an educational tool. So we have two speakers today, Dr. Kajal Patel. She is an assistant professor of medicine at Emory University. Dr. Patel completed medical school, a master's in public health, and an internal medicine residency there at Emory. She now splits her clinical time between the Emory Clinic and Emory at Grady. She works closely with Dr. Mary Solis, our other presenter and assistant professor also at Emory. Dr. Solis completed her medical school at University of Florida and her internal medicine residency at George Washington University prior to joining the Emory Clinic. Dr. Patel and Dr. Solis provide primary care and supervise learners at varied stages. They're interested in artificial intelligence, its application to clinical practice, and appropriate supervision of these rapidly developing tools among our learners. They have grown a presence in this sphere, developing an elective course for medical students locally and leading workshops training clinical educators nationally. Please join me in welcoming Drs. Patel and Solis.
Wonderful. Thank you so much for that introduction. We are excited to be here with you, though virtually. We are there in spirit as well.
Agreed. Very happy to be talking with you.
Awesome. So we have no disclosures. By the end of the session, you'll be able to assess AI outputs for accuracy, reliability, and appropriateness in the context of clinical care, apply prompt engineering techniques to improve the generated outputs, and identify practical ways to really integrate these tools into clinical workflows and, most importantly, medical education today. All right, we'll start off with a general introduction. So LLMs, or large language models, are, in brief, a type of artificial intelligence that's been trained on massive amounts of text data to be able to understand and from there generate human-like text. It can interpret information to better be able to summarize, answer questions, engage in back and forth conversation, even generate new information, as we've seen as well. It's important to know that these tools are not necessarily designed to generate truth, but really the most likely answer based off of what it's already been trained on. And so at times this can create an illusion of intelligence where there are answers, even if wrong, can sound really reasonable to us. And so it's important to keep this in mind as we are using these tools to support our work, support our teaching, but not to replace our own clinical reasoning skills. Still, there are many situations where these tools can be pretty accurate. For reference, the threshold for passing the USMLE is a 60% accuracy, and there are a variety of platforms that have well surpassed this benchmark, with Open Evidence being the first to reach that perfect 100%. There have been many studies looking at the clinical use of these tools, and this is one example. This figure is from a retrospective study where they looked at how AI-generated recommendations compared to physician-provided recommendations across 461 urgent care encounters. For the most part, the scores were pretty consistent, but when the AI and physician recommendations differed, it was actually found that the AI was tended to be rated of better quality, identifying those key flags, sticking to guidelines, whereas the physicians were a bit more adaptable in their recommendations, as you can imagine. And this figure is from a recent article in Nature comparing tools across various clinical tasks. We're finding that as the technology is continuing to improve, the actual gap between the general use AI tools and the more specialized clinical tools is becoming more and more narrow, which is crazy to believe. In this particular study, they found that the general LLMs, Gemini, GPT, Claude, actually outperformed open evidence and up-to-date AI, which is crazy to think of. And they looked at multiple metrics, medical question answering, clinical reasoning, healthcare-related tasks, many other metrics that they created for the purpose of this study. And Gemini, we see from this question bank scored the highest accuracy, 97.4%, which was incredible. Okay. Looking through, the LLMs were pretty similar when it came to actual clinical correctness, but where the general LLMs won out was in terms of completeness and in clarity for the clinicians. Suggested that the problem with some of our clinical tools was not the medical knowledge, but really the communication and language piece, which is just rapidly developing in many of the tools out there. By all means, we'll take this information with a grain of salt. These are not true clinical scenarios that were used, but it really brings this point home that these tools are developing really quickly in a very short amount of time. As we carefully consider incorporating this technology into clinical care, we have to be aware of the various threats. Not all tools are HIPAA compliant, so personal information that is directed here could potentially be shared to a third party, pose a breach of privacy. And there are cases where tools, particularly earlier editions, have generated inaccurate, though very convincing sounding information with fake or irrelevant citations. There's a concern for copyright as well. These tools are already designed to compile materials from a vast variety of sources, but they may not always have the appropriate authorization to do so, or may not appropriately acknowledge all of the authors. And there's bias as well. Unfortunately, if these tools are trained off of already biased or unrepresentative data, it can potentiate those same stereotypes and biases. There's also a concern for information poisoning. When there's a significant uptick in the amount that's being published on a particular topic, it can affect search engines and really create this illusion of something being fact as opposed to simply being popular, creating additional false confidence in the generated answer. And lastly, this risk for automation bias, an over-reliance ultimately on the available technology, where the tendency could be to unnecessarily second-guess our own clinical reasoning skills, answering questions that we already know the answers to. As an example of the caution that we should have as we interact with these platforms, we have depicted here a leading question, the dosing of armour thyroid used for the treatment of hypothyroidism. We see a beautiful fleshed out answer here, but unfortunately it skips over the fact that armour thyroid is not the standard of care when it comes to the treatment of hypothyroidism. And so we have to be really cautious when we are asking these tools questions in subjects that we're not already an expert in. Here is an example of some source misattribution. We had asked a tool for a summary of a specific NEJM article. We see a summary below and the appropriate articles referenced, but I guess referenced in general in the summary here, but it is quoting a secondary source. We actually don't see that specific NEJM article listed in any of the references here. It's primarily quoting an article from Nature, and this is that article below with a different list of authors. So we have to be really careful in that the summary that was provided seemed very reasonable, but the sources didn't really seem to line up. And this is something we ran just this week. And of course, in thinking about potential harms, we have to take a moment to acknowledge the environmental impact. The training and running of these LLMs requires a massive amount of energy, unfortunately still being derived from fossil fuels. And it's not just the running of the AI tools, it's the water to cool the data centers, it's the physical waste from the disposal of hardware. So something for us to be keeping in mind is hopefully we'll learn more and be able to use this technology well. Right? So in all, we have to be cautious with how we use the available tools, taking a safety-first approach when reviewing the outputs, validating the information against trusted sources, and maintaining clinical oversight, and also being transparent with how we're using this. So in spite of all of those potential threats and additional caution that we need, we find that these tools can be really helpful to augment our own practice. They can be helpful for our patients in translating medical jargon, creating easy-to-read, patient-friendly handouts, helpful for us in the completion of administrative tasks, for example, patient letters, letters of rec. They can also be used as an adjunct to our clinical reasoning, really compiling the available evidence to be able to answer very specific clinical questions. And as we'll be focusing on today, adapted for learner education.
So I'm going to talk to you a little bit about some of these tools, and I might give away my age a little bit, but I trained at a time where we had pocket medicine for reference. And so those were the times where I knew what section to go to when I needed to reference a specific source or used as a clinical decision support tool. But these tools are here, and we're going to talk about a few of some of the large language model tools that we have available to us. And they have created a new dimension of access to information in real time for a lot of our trainees and us. And so we're going to look at Open Evidence, UpToDate, Gemini, and a few others. And so Open Evidence, it is a AI-powered medical search platform. It is purpose-built for clinicians and delivers rapid evidence-based answers synthesized from up-to-date current medical literature. So if you had an article that was published yesterday, you would probably be able to reference it and find it on Open Evidence. It is free to use and register with your NPI. And it has signed contracts with JAMA, New England Journal of Medicine, and several other platforms. So you have access to a lot of the content from a lot of our journal publications. It is got several other features that it is trying to incorporate. So as you will see, we have things like dot flows, which I will talk about in a second, but it's got newer features like scribe function, documentation function, and these tools are constantly updating what features that they are introducing. I wanted to focus on dot flows for just a second. This is a way to create a structured template with a prompt that you would have created based on how you want information retrieved. And we're going to look at one example as we do a case later on. And but just wanted you to be aware of some of the new features that are being incorporated into some of the other tools. So this is just an example of some of the ones that are available through Open Evidence. You can see that you have one that says dot cross trial, and so it synthesizes clinical trials in a structured format. But we'll review this in a case later on. Next, we're going to talk about Doximity. Doximity's versions of its AI platform started out as Doximity Answers and then later Doximity GPT, and now it is Doximity Ask. And it is Doximity's answer to a medical search engine. It does include broader sources like the CDC, FDA, and it also does have signed contracts with BMJ and the Lancet. It is free to use with the Doximity account. And I think of Doximity more as our optimized AI assistant for physician workflow. It's really great at documentation and communication. It does allow you to get access to free full text articles. And so you can see at the bottom, I have Nature Medicine, Annals, the Lancet, New England Journal, and BMJ as my preferred sources of articles that it would pull from. But you are able to get a free PDF, 5 free PDFs each month based on whichever specialty or specialty publications you are trying to pull from. So Doximity also does incorporate several other features. So as you can see, we have things like a scribe function, there's a dialer function, a fax function, but it's got other tools inbuilt as well. So you can look up drugs, calculators, and it also does have a template section where you can have a structured template based on certain prompts that you use for information retrieval. Next, we are going to talk about up-to-date, and I believe your institution also has access to up-to-date. You sign in with your up-to-date credentials, and some up-to-date features incorporate Expert AI, which is up-to-date's answer for an AI platform. So the AI layer for up-to-date is basically pulling from content from up-to-date itself. And so very useful for confirming guideline-based management, standard of care recommendations. It does reference only up-to-date content. So if you had an article that was published yesterday, you might not find it on an up-to-date reference at that point. And so one of the features that it does incorporate is it gives you a nice condensed summary of whatever question you're asking. So you will see, will make things like, I have assumed, gives you certain assumptions you're making based on the prompt that you've asked. It gives you a nice condensed summary, and then the references that it is going over. And for those of you that have access to or are members of American College of Physicians, you do have access to Dynamed. And Dynamed has its Dyna AI, which is Dynamed's AI platform. It is a clinical reference platform. Again, pulls clinical guidelines, systematic reviews, peer-reviewed literature. You would sign in with your own account, or if you had ACP membership through ACP. This one focuses more on point-of-care recommendations and evidence-based summary, so it's really good for bedside rapid clinical decision support. It does have a few new features. It is now collaborating with MicroMedX. So from a standpoint of drug dosing, starting with medical calculations, you are able to access MicroMedX content through Dynamed. And it does also now have a new partnership with New England Journal of Medicine. So you are able to access articles now through the New England Journal platform collaboration with Dynamed. Perplexity AI. Some of you may have heard of this, some of you may not. It is a broad research-based AI tool. Now, it's got different AI-based large language models. So you can have Claude, Gemini, GPT. It's got different versions of it, and some of them require subscription, some don't. But you are able to use this for free with and get 5 searches a day. This pulls from all the web, so anything that's out there, it's going to find. And I find that this one is very helpful for exploring topics that are outside of medicine and popular science topics. So an example I'll give you is if a patient came in and started asking you about what diet is best for type O blood type. So it'd be a good tool for you to look at what's out there and show the patient where some of the references might be coming from. For example, is it a Facebook blog or something that just is not a clinically relevant reference? And next, we're going to talk about Google Gemini. And so Google Gemini is Google's AI assistant. It's really good for content creation and presentation design. Again, it's got a free version available, or you can subscribe to some of the more advanced features. It's good for generating slides, diagrams, educational visuals. It does also have a GPT feature where it will pull and summarize guidelines, similar to what Mary was describing earlier with the new Nature article, when we're comparing some of the tools with some of like the general reference AI tools with some of our clinically focused tools. And then Copilot is Microsoft Copilot. You would log in using your credentials. We have access to it through our Emory platform. We do note that it's got security at Emory. It's one of our preferred ones because data is not stored and they have guaranteed. So if I needed to put in any patient-sensitive information, we know that it's not stored within our institution. It is good for generating images, PowerPoints. You have a ChatGPT function within PowerPoint itself where you can create slide decks. I think of this more as a good productivity assistant because it also does draft, summarize, and automate your work across all the different Microsoft platforms. And so the quality of your AI output is really determined not by the AI tool itself, but more by how you ask a question or prompt. And so AI is a pattern reader, and so better prompts lead to better answers. And prompting is becoming one of those core literacy skills. So knowing what to ask is just as important as knowing where and how to look. So these are a few tips and tricks for prompting. So be specific. An example would be provide a list of the 5 most common etiologies of microcytic anemia and the tests used to evaluate each etiology. Give it some context. I'm working with patients who have kidney disease. Please make a list of common high potassium foods to avoid. This will be given directly to patients. Set the tone. Provide a kind, supportive, professional reply to this email. Give it some parameters. So set a length. Prepare a 1-paragraph response. Respond to this in no more than X words. Numbered requests. Create a case about temporal arteritis for third-year medical resident, including 1, presentation, 2, physical exam findings, 3, laboratory findings. Act as if. Act as if you were a physical therapist. What exercises should I try for a rotator cuff strain? Give your prompt feedback. Give the tool some feedback. The tone of this message is too formal. Please rewrite the message as 20% less formal. Request tables. In a table format, please compare the causes of hypoparathyroidism. So with looking at advanced prompting, this is an example of a case, a 58-year-old man with alcoholic-related cirrhosis, complicated by portal hypertension, esophageal varices, previously banded, and recurrent ascites, presenting with 2 days of progressive confusion and somnolence in the setting of lactulose, non-adherence, melena, and worsening ascites, lower extremity edema. So weak prompt would be something like, tell me about cirrhosis. A better prompt would be, act as a hepatology attending, teaching PGY2 residents, create a 10-minute teaching session on decompensated cirrhosis, emphasizing inpatient management, common mistakes, and board relevant pearls. But an even better prompt would be where you are giving the tool a lot more context and clarity. So providing the patient's presentation, labs, and history, giving it some limits. So setting boundaries like the length and bullet formatting. I could say it in 150 words or less. Giving it an action or execution item. Define the task. Is it inpatient management? Is it board pearls? It could be both. Amplify. Narrow the focus to specific guidelines. So focusing on the AASLD guidelines, and then review, evaluate what output you're getting, and again, critically evaluate it before applying it to any patient care. So I'm not going to read this all out, but as you can see with this prompt, given it more patient information, and I'm asking it to use specific guidelines, giving me step-by-step management, and then also things like giving it a parameter, 250 words, and how I wanted to organize the output that it's going to give me.
Wonderful. So next we're going to transition to the application to medical education. All right. And so whether we like it or not, as you may already know, our trainees are already using these tools. As Dr. Patel mentioned, in the same way that some of us older folks have been used to pocket guides or even up to date more recently as how we access information really quickly. These new tools that are available are really just changing the dynamic of what is at our fingertips, both for full physicians, but then also for different levels of our learners. We had the opportunity to lead an elective course for our 4th-year medical students, really designed to introduce them in a structured way to many of those generative AI tools that we discussed, highlighting responsible use as we think about patient care. And we have our initial survey data shown here. We see that a significant number of our students were already using AI for both personal use and for clinical use, but a much lower percent felt confident in how they were using AI or proficient in their use. And here we have more data highlighting that overall they felt really hopeful in the future about the future impact of AI, but overall low understanding prior to our course and low comfort with its use. Okay. And so we know that AI can be really useful for summarizing, organizing, generating first drafts. And really, these same skills can be applied to medical education, and that's what makes it so useful for this field. It can be helpful for the creation of study aids, quickly adapting content to various levels of learners, creating simulations for teaching purposes as well. As educators, it's really our responsibility to supervise our trainees and really fill in the gaps where the AI may fall short. We find that there can be challenges to being able to verify the accuracy, but it's up to us to help with that, to also help to point to current guidelines, to encourage clinical judgment in the midst of its use, highlight nuance, discuss local practice patterns as well. There's a lot that's been published on the teaching of appropriate AI use amongst our trainees. This first article is from JSHIM discussing the opportunities that attendings have when supervising their trainees and how they use these tools. It really emphasizes that we should encourage that first pass to be done ourselves, really the creation of a differential, so forth, to be done initially with the human brain. And then from there, we can augment those responses using AI to really cross-check or kind of broaden differentials, for example. The second article really emphasized the use of a set tool to be able to judge the trustworthiness of given AI tools, really emphasized assigning ability, integrity, benevolence to really understand whether a given tool was trustworthy for the conduction of clinical or educational tasks, actually. And this final paper is from NEJM. This one really highlights the DEFT AI framework that we'll be reviewing today, really as a structured way to coach our trainees and how they interact with these tools, and we'll be reviewing that in detail. Really, these articles are primarily focused on attendings as they are coaching and providing feedback to trainees, but really this knowledge is accessible and helpful for all levels of teachers. We find that our residents, our students, all of you all are teaching those below you. All right. This figure from the NEJM article summarizes the various outcomes our trainees can experience as they interact with these generative AI tools. There's this critical period where our trainees are developing clinical reasoning skills in order to develop basic competency, ultimately. With early reliance on AI for those skills, unfortunately, there is a risk of one, never skilling, a failure to learn the actual fundamentals. Two, de-skilling, actually losing the skills that you may already have. And three, unfortunately, mis-skilling, kind of learning incorrect behaviors as opposed from biased or inaccurate outputs from these tools. On the other hand, the answer is not avoidance of AI. We find that learners who do not learn how to use these tools also miss an opportunity for enhanced practice. And so the larger question is, how can we teach our learners to develop their own critical thinking skills, establish competency, but then also take advantage of the available tools to really augment their own practice going forward? And so that's where the STEPT AI framework comes into play. It stands for diagnosis, discussion, and discourse. This is how we identify when our learners are using a tool. You can ask questions like, what specific AI did you use? How did you use AI in this process? What prompts did you enter into the app? E is evidence, checking what the learner's input was, checking to see what the AI knows versus what assumptions are being made. You can ask questions like, how did you evaluate the use of the AI here? How can we improve the use of the AI in this situation? Okay, feedback. Separating the learner's reasoning from the AI's reasoning and to really understand the clinical picture. How can, so sorry, I think I mixed this up. Evidence, how can you verify the generated outputs, and is the AI that you use shown to be accurate and safe? feedback, how can you evaluate the use of the AI in this case? How can you improve the use of AI? And then finally, teaching, using this as an opportunity to really promote the verification of the AI outputs, cross-checking against guidelines, really teaching our learners to interact with these tools appropriately. Right. The paper also describes two models of how we can work with and collaborate with AI. We can function one as a centaur, kind of delegating tasks to the AI with careful supervision. We can use the AI for summarization and drafting, but then use our own human judgment when it comes to that decision-making piece. This can be more appropriate for high-stakes tasks. We can also function on the other end as cyborgs, is what they describe it as, collaborating with the AI without really evaluating. This can be really efficient for low-risk tasks when we're thinking about letter creation, etc. But there's this risk of over-reliance on the technology as well, and we have to be mindful of that. The goal isn't exclusively to be one or the other, but to be able to be fluid, to actually shift between the two based off of that particular task and its complexity.
Next, we'll move on to some cases. And so for our first case, we have you and a medical student are evaluating a patient in clinic with newly diagnosed diabetes. During the visit, you find that the patient is open to a new medication, but would prefer to avoid insulin, if possible. The patient's history is notable for CKD stage 4. So how could you start with any of your AI tools from a teaching standpoint, and also helping out our patient? And so you want to create a chart of available medication options to teach your student and facilitate a discussion with your patient. If any of you have an AI tool that you have available on you, I'm not sure if you have your laptops or your phone, but think of like how you would start writing out a prompt for this case and what would be helpful components to include in your prompt. And I think in the interest of time, we're just going to go ahead and show you our next prompt. Next slide, sorry. And so building a prompt for this case, I am seeing a patient with type 2 diabetes and chronic kidney disease with a GFR of 25 in clinic, giving it some context. I'm giving it some limits and specific parameters. So create a table of non-insulin medication options to treat diabetes, include columns for side effects and cost considerations. And then I want to also amplify the output that I'm going to get. So act as if you are an endocrinologist and include high-yield tips for a third-year medical student. So for the short time, and if those of you who are out in the audience have actually tried this on your prompt, on any of the tools, it did take less than a few minutes to generate this table, actually less than a minute overall. And we get a pretty useful table that reviews medication options that we have for our patients. So something to consider as you're working with a student or resident, just in real time working with our patients. And one of the things I did want to point out is you still have to use your clinical judgment. At the very top, one of the examples we got for a treatment option is metformin, but it does say we would generally avoid it if eGFR is less than 30, but this is something where it shouldn't have incorporated into the table itself. And so you can tailor your output using your target audience. So I could customize my column headings, change the format from a table to another format. I can rewrite some of this information as patient education, for patient education handouts. So as we move on with this, your medical student is interested in learning more about diabetes management and how could they use an AI tool to create a learning plan. So I'm not driving. I apologize. We're at two different sites, but here's an example of one of the prompts that we would use. So what are my learning objectives? Create I want to create a 2-hour study plan focused on the diagnosis and management of diabetes in the outpatient setting. Include key papers, common board questions, clinical pearls. So you want to give, again, all these, whatever output that you do want to get out of your learning plan. Be specific with what objectives you want, give it a concept map, set up a reading plan. Do you want test questions out of it? Do you want specific papers that you would want your learning plan to come from? Next, we're going to show you a short video clip of, this is on Doximity. This is how we would have plugged in our prompt. So again, you can see that it's thinking, and you get within like a few minutes, seconds almost, a good starting point for what you're looking for in terms of diabetes management and medications to consider. It goes over landmark papers because we asked for it, gives us some board questions and clinical pearls. And one of the things would be to always look through the content and revise your prompt. And you can also use some of these, some of the content that you generate as a starting point for creating lectures, other chalk talks. And always review references.
All right, for our second case, we have a 70-year-old woman who presents for follow-up. Her medical history includes trigeminal neuralgia, generalized anxiety disorder, and most recently atrial fibrillation with, unfortunately, a high symptom burden, currently having palpitations, dyspnea, and exercise intolerance. She has been on amitriptyline 50 milligrams nightly for 10 years, which has provided good control with both her trigeminal neuralgia pain and her anxiety. Her cardiologist has recommended discontinuing amitriptyline due to concern about its contribution to her high AFib burden and QTc prolongation risk. She was transitioned to sertraline, but experienced severe worsening of her anxiety and no improvement in her facial pain. She's requesting to go back on amitriptyline. And so you are working with a trainee and you find yourself in a scenario that is similar to this figure that's depicted. This is a complex clinical question, and you suspect that your trainee may be using an AI tool to help answer a question, or you may be actively seeing them type this on your phone. And so this is a great opportunity to incorporate that deft AI framework that we spoke about to really coach the use of those tools. And so we will simulate that here. So, pretending that we are the attending in this situation, you may open with, this is a tricky case. What is your working assessment?
Amitriptyline seemed to be helping the patient's trigeminal neuralgia and anxiety, but seems to be worsening her AFib. I think we should try a different medication. It looks like carbamazepine as first line.
Yes. Did you use an AI tool to help? And what prompt did you enter?
I've tried Doximity before. I asked it for medications used to treat trigeminal neuralgia.
How can we verify the AI output? Is it appropriate for our patient's case?
The listed sources are guidelines, but from European journals that I don't really recognize. The information seems pretty broad, nothing specific to our patient case. This article lists arrhythmia as a potential side effect of carbamazepine, so maybe we should find another option.
Yeah, that's a great catch. What other information do we need to refine our prompt?
I think I should include her history of AFib and the side effects she's experienced with amitriptyline. I think her age would also be helpful too in case there's other considerations from the Beers criteria.
Wonderful. And from here, you can conclude with a discussion of false assumptions that the AI can make without the proper inputs and the clinical information that's needed. In this case, maybe we'd review the available medications, maybe we'd consider gabapentin as an okay bridge, kind of balancing the pros and cons with that, so Beer's criteria list, so forth. But yeah, great opportunity to use that AI tool as an opportunity to now teach.
So for case 3, you're an attending physician reviewing dyslipidemia management with the resident. Your trainee has thoughtful questions about the utility of a coronary calcium scan. You would like to parse down the updated guidelines into a brief chalk talk. And so how could you use an AI tool as a starting point? One of the examples we're going to show you is how we created a dot flow for a chalk talk. And so I'm going to show you the exact prompt that we've got for like our dot flow chalk talk. So you can see it says develop a concise evidence-based teaching presentation. I've given it some critical rules. I've got the output format that I would like it in, starting with title, learning objectives, give me a clinical hook, one-line takeaway, an outline, some landmark evidence with the trial names, the population, give me some clinical pearls, common mistakes, board pearls, some take-home points, and an optional one-slide summary. So again, this is an example of a prompt that you can save. And so when I am using my dot flow, all I plugged in was the 2026 lipid guidelines. So you are saving yourself time from having to go in every single time and put in what output you're trying to get out of each of these tools.
And these can be shared.
Yes.
Yes, Dr. Patel shared this one with me, and I'm definitely using it.
And as you can see, I've gotten, some valuable information from the lipid guidelines that just got updated. Had to call back several patients a week after I'd seen them just to say that there'd been new changes and recommendations, and they were not happy with me. And we can skip through towards the end, but this is just more so to highlight that, it kind of gives you all the output that I wanted in the format that I wanted. It's highlighting the clinical trials. And then close towards the end, you're going to see where it gives me an optional one-slide summary. And that could be a good starting point for you to use in developing a talk for yourself, creating a PowerPoint.
I think it's coming up.
Okay. It's got some board-like questions, take-home points, and here's the optional one-slide summary. And one of the things you'll notice is this was being alluded to earlier with some of our clinical tools not being as advanced as some of our general purpose tools, but it's a good starting point. And what we're going to show you next is how we took what we generated out of this chalk talk. So basically copied the chalk talk into Gemini and asked it to help create a slide deck that I could use to teach residents or students with. And in the few minutes or seconds that it took to build that, you can see that I got about 13 slides. All, they look fairly decent as a good starting point. Obviously, you would review for content and look and make your own edits. But I think in the short amount of time it took to generate this slide deck, I think of, years ago, how I would spend, or even just a year ago, hours working on PowerPoint presentations and coming up with content for slides. And the next one we're going to show you is Microsoft Copilot. And so within PowerPoint itself, you can get a plugin for MS Copilot or have a ChatGPT plugin as well. And you can actually just type in a prompt asking you to give you guidelines and create a slide deck. And this is one that we generated with Microsoft Copilot. And you can see if I had to just create this from scratch, it would have taken me a whole lot longer than about the 1 minute that it took for this slide deck to get created. This is just an example of some of the output that we are getting from some of our AI tools. And so opportunities for teaching with these tools, again, creating a chalk talk lectures, generating multiple choice questions, drafting clinical cases, creating student handouts and educational materials, identifying recommended guidelines, summarizing guidelines, and also very helpful for streamlining administrative tasks, creating patient handouts and educational materials, drafting prior authorization letters, DME letters, letters of medical necessity, for all our program directors out there and anyone that writes letters of recommendation, performance evaluations, trainee feedback summaries, drafting your after visit summaries for patients, appointment preparation instructions, creating consultation summaries, discharge summaries, and notes. The list keeps growing. And so our final takeaway is these tools are helpful for administrative tasks and are meant to augment, not replace our clinical reasoning. So always verify your output. These tools can be adapted for medical education, and we must teach appropriate use among trainees. We're already seeing that everyone is using them, whether in personal use or in the clinical talks, in the clinical context. So we have to know what our trainees are using. Review everything for accuracy and use caution with using these tools, especially to answer questions that you are unfamiliar with. Do not use any identifiable patient data. Even if it says it's HIPAA compliant, you need to make sure that your institution has a BPA or business partner agreement signed with that tool before you put in any patient-sensitive material into any of the tools. And always be transparent about your use. Review your organizational rules and policies around AI use, always. With that, we will take any questions.
All right. Thank you, Dr. Patel, Dr. Solis. We'll open it up for questions. We have 2 microphones. We'll ask that you use the microphone to ask the question so our online folks can hear. And I'll remind you, if you're viewing online and have a question, please enter it into the Q&A section, and we'll ask that for you. So who would like to start?
Thank you so much. This is Dr. Monica Newton. I'm the Family Medicine Program Director. So thank you guys for coming here and sharing this important topic. I was curious if you would just briefly comment on the use of AI in scholarly writing. Most of us do a little bit of that, and I think I'm shocked at how much people lean on it because I've always been afraid that it would somehow make the work not original. So I was wondering if you could comment on that.
Yes, so there are several tools out there that are, so for example, with Gemini, there's used to be for Google Notebook LLM. A lot of people were using that to start writing processes and things like that. So in terms of actual AI use for writing, you will notice that a lot of places where you were trying to get published will ask you, how did you use AI? Did you disclose your AI use and in what context? And so again, being transparent about how you've used it. So was it more for, did I use it just to reorganize sentences, or did I ask it to draft the whole paper for me? Things like that. And so we're starting to see where even submission for case abstracts at local conferences, national conferences are asking, did you use AI, in what capacity, in what context? And again, this is where transparency needs to be very important about how you've used it and what you're using it for specifically.
Yeah, and I'll take it a step further. For CME presentations, the ACCME is now requiring you to disclose how you did it, what you did it on, and who reviewed it for the accuracy. So, any other questions, comments?
Just raise your hand. I'll bring the microphone to you.
Nothing?
Anything online, Jennifer? Oh,
So, Dr. Solis, you mentioned that something was good for a first draft. So, to me, I'm back on my scholarly activity question again. So, I think most of us have said, hey, I write it and then I ask, like, how to make this more concise. How do I get it to 200 words? That kind of thing. But you did mention a first draft of something. So, I was curious about that. It was a tool that you mentioned that I think that was good for a first draft.
I'm trying to recall. So I think Dr. Patel went over the tools in general, but he kind of went through each of the specific tools. But in thinking about drafting, we've found that Doximity has been a little bit better in terms of language as opposed to like open evidence and some of the other clinical tools. But yes, in general, these tools can be really good at that language piece. I think that would be an absolutely appropriate use. Like we've, done that first pass ourselves. We've put in that initial input, and now we're asking for help with that language, which I think would be reasonable as long as it is, clear in how we're using it. Mm.
And again, we mentioned some of the administrative tasks that we're using it for. So for example, letters of recommendation. There is a specific way to be able to say that you have used AI for help with generating this letter of recommendation, for example, for drafting some of the feedback that we're giving you and how the tool was used. But that it has been reviewed, like you said, and in what capacity the review was done.
All right. Thank you, Dr. Patel. Thank you, Dr. Solis.